Good morning. It's great to see you all here. My name's Nikki Buckley. I'm one of the directors at the Centre for Science and Policy. And this is a fantastic culmination, we always feel, to the academic year and to seeing our network brought to life here in the room. So we know we have some of our policy fellows here from UK Civil Service and beyond. We've got others in the civil service who are interested in our work, including science and engineering fast streamers. Great to see researchers here as well from Cambridge and many other universities, as well as friends from other universities, from learned societies, industry, and so on. We are very grateful for the conference sponsors and supporters. These include Overton, the world's largest searchable database of policy documents and calls for policy engagement. We also are supported by the Centre for Pandemic Risk Management and Cambridge Zero at the University of Cambridge. The conference is being recorded today and there will be a photographer. If you don't wish to be photographed, please could you go to the front desk and tell my colleagues and they will make a note. This does mean that the Q&A is also being recorded. Today isn't run on the Chatham House rule and tweeting is allowed. So the hashtag is up there as CSaP Conference 2025. We'll also be putting a write-up on our of sessions on our website afterwards, as well as the recordings. So I know you'll have a difficult job choosing between two sets of 3 parallel sessions this morning and this afternoon. We're going to have short pitches from the chairs of those sessions to give you information and a bit of a roundup from the end of the day, so you may get some insights from the ones you haven't been able to attend. During the lunchtime session, you'll have seen there's information on the networking and the tables available in this room, so do please make your way around some of those. At the end of the day, we have networking drinks, and I hope you can stay for those. If we do hear a fire alarm, the fire exit in this room seems to be marked here, so please use that. So it's my great pleasure to move on to the first session of the day on life sciences, healthcare and economic growth. And some of us have had the advantage of hearing longer form versions of these from our 2 distinguished speakers today. But we've asked them to boil down and give us fresh insights into their perspectives on this topic. So the first speaker is going to be Lord James O'Shaughnessy. He was Minister in the Department of Health from 2016 to 2018. He's a co-founder of New Market Strategy, a consultancy improving access to health innovation. He's a life peer, visiting professor at Imperial College, a friend to CSaP through our advisory council, and he chairs the Cambridge University Health Partners. So he's going to speak about his perspectives on how life sciences innovation can save the NHS. Over to you, James.
Thanks, Nikki. Thank you very much. It's a pleasure to be here. And starting with a provocative title, and as you can tell from this is going from the title, it's going to be a short presentation in 2 parts. First part, I must warn you, was a bit gloomy, and then it gets a little bit more optimistic and productive. But ultimately, I want to understand or talk about today and help us understand as we get into the panel discussion, really just sort of grounded in the state that we're in healthcare. And by the way, everything that I'm going to say is true of the NHS is true of almost every other Western country as well. Why we are in such a state, again, these structural drivers, and they're not unique to us either, but then also where the opportunities are for the life sciences to make a difference to both the delivery of healthcare, improving health outcomes, but ultimately to growing the economy, which is fundamentally the problem that we and other countries are suffering. We're in a kind of zero-sum game at the moment, which means that we have to make hard choices between where we allocate capital, which is obviously very difficult and means that very important parts of our public services do not get the funding they need because of these healthcare pressures, and that is obviously unsustainable over time. So let me crack on. First of all, on the state we're in, it was a pretty blunt statement from the Secretary of State, the new Secretary of State, when he came in just nearly a year ago, to say that the policy of the department is that the NHS is broken, and has subsequently been reiterated, of course, by himself, by other ministers, other cabinet ministers, and by the Prime Minister. But I think actually he was quite right to say it. And the reason we know he was right to say it is that having commissioned Aradazi, a former health minister, obviously under Labour, to undergo his investigation, that was absolutely the position that Ara described in extraordinary length. And with, I think, for those who haven't read it, I would strongly encourage you to go and look at the technical annex and the analysis within that. It is probably the broadest and deepest analysis that's ever been done of why the NHS performance and key factors driving that. And if you really want to understand the mechanics of a system and how it has downgraded over time, it is worth looking at. And one of the things that he did pick out, no, I won't go through all of these metrics, performance metrics will be familiar to everybody, is one of the key things he pointed out was that since the financial crisis was an underinvestment in capital. And by capital, I mean capital of all forms, including technology. And that is really very fundamental because views differ about what the capital gap was or would, if we'd spent at in the same levels of the 10 years prior to that, what it would have been. But we're talking of tens of billions. And if you view the NHS simply as a business, it is impossible to run an improving business if you starve it of capital. And you ask anybody who runs any institution, public or private, and they will tell you that is true. So that is the cause of some of the consequences that we have seen. So Ara was very, very clear about that. And if you look at some of the core outcomes of this, and this is the bit that I guess is perplexing everybody, but this is where capital comes in. We are spending more than ever on healthcare. Healthcare spending, even though people in the NHS will not feel that it is going up fast enough, has been rising all the time and will continue to rise post-SR into the future at around between 2.8 and 3%, depending on which measure. So healthcare spending is rising. The second chart shows staffing. So again, one of the myths is that there's not enough people. There are more people than ever. In fact, there's been about a 20% increase in the number of people working in the NHS since 2019. And the third chart is around productivity. Now, again, you can have arguments, no doubt we will, on the panel about how you measure public sector productivity, but this has been measured consistently over time, and it is lower than where it was. So if you think about that, that is more money, more people, and lower productivity, which actually implies that you have a capital and technology problem, because the way I described it is like, imagine sending more people out to do even more work with worse tools to do that job and then expecting they will be more productive. It is just impossible. It cannot happen. And that is fundamentally the situation that we find ourselves in. And unfortunately, the consequence of that is satisfaction is historically low. Now, what's interesting about this, and there's some changes in methodology which is worth flagging up here. But a lot of this actually started at the point during COVID. So COVID, the pandemic, you had two things going on. On the one hand, a massive sort of rallying to the national flag, particularly the NHS, but obviously the cessation of lots of non-urgent activity. And this seems to have been a kind of flip in the mindset. And of course, ever since then, we know that we've had ballooning waiting lists across primary care, secondary care, ambulance waits, A&E, and so on. So we are in a real problem now that opinion, which has always been sort of strongly supportive of the NHS, is becoming much more critical. And interestingly, I haven't got time to go into it today, if you look at, or in much depth, but if you look at how that's changing people's behaviours, more and more people are starting to choose to get their care elsewhere. And that's actually a generational shift, which I will talk a little bit more in a moment. So that's kind of the state we're in. And then the reasons for that. Now, I've already talked about, obviously, the capital issue, and we might return to that. But fundamentally, you've got a problem of a growing, ageing, and increasingly sick population. So that creates inexorable increases in demand. And you can see that here, the protected change in population for the over 85s. Now, of course, terrific news. We're all living longer, or have been living longer. But are we living longer in good health? No. And the number of people who are living or projected to live with major illness. So as you can imagine, that is a pattern not just of more people with, on average, the same healthcare needs, but more people with, on average, greater healthcare needs flowing into a system which, yes, is getting more money and has more staff, but remember back to where we were, has been underinvested in capital and technology, and so those staff are less productive than they were. And, of course, that explains all those waiting lists and the other pressures. What's also been happening is, in addition to the ageing and growing population because of ageing, not because of rising birth rates, that's obviously they're falling and below replacement rate, but ageing population and inward migration, is that we've also got growing demand from out of work or partially in work populations. And this, in some ways, is the most alarming chart because, and again, you saw a big uplift in this as a consequence of COVID and continued, indeed, projected into the future as well, is that these are people who would have otherwise been in touch with the workforce in one form or another who aren't, and for whom there is obviously two impacts fiscally, one of which is they're not generating tax revenues, and the other is which is they are getting social security payments of one form or another. And it's not just unemployed people, interestingly, it's also people who are checking out of the labour market entirely, so even further from the labour market, if you like, and those who are in employment. So those are people who are in employment, but by definition, because of the nature of those illnesses, that has a marginal impact in their ability to work full-time or work to their full capacity and so on, which overall has an economic impact. And if you wanted, and I think the government, to their credit, have been very clear-sighted in pointing this out, that is where one of the big drags on growth comes from, is this group of people. And one of the big questions is how can we create a more preventative healthcare system that specifically helps these people, as well as helping the general population. So that ageing, growing population, detachment from the workforce due to ill health. And, of course, that good news about life expectancy, actually, at best, you could say it's plateaued. Now, again, there are some effects here from COVID, inevitably, because the nature of the disease was much more deadly for the very elderly people. But nevertheless, if you look at these charts, this is the latest data I could find from 2024. There might be more recent data. You can see that it is plateaued. We are not on that inexorable rising curve that we've been for many decades. And indeed, that is expressing itself now also through, or the health impacts driving that life expectancy are also expressing themselves in the rise of morbidities. And the distribution of those morbidities between, among people, or the higher distribution of those morbidities among people in the most deprived areas of the country versus the least deprived. And of course, you kind of know this, that instinctively know this, but when you see those figures, you see the increase of the number of people who are moving into these categories. And actually, the interesting thing is, of course, there's equalities between both of them, between the green and the red, but actually all of them are moving rightward over time. So actually, this is a whole population effect. You know, slightly dramatic title, but meantime, we are on the road to fiscal ruin. It's just worth pointing this out. One of the reasons for that is because of that growing healthcare demand, the reasons for which I've just been going through. If you look at that OBR projection on health spend, you know, that's nearly a year old, but nevertheless still pretty accurate. And then critically, you look at what that means over the very long term to borrowing. Now, the Japanese are managing to pull off at the moment being somewhere around 200 to 250% of GDP. But I think if every country in the world was doing that simultaneously, and bear in mind what I said, is that what we are suffering is possibly worse than many other countries, but it is not actually that different in kind, then clearly that is an unsustainable position. And it becomes even more unsustainable when you think about those new demands on public spending. And I was just saying to Nikki just before this, such are the times we live in, you write a presentation, you put it in the night before, and literally the next day it's changed. And we're now got the Prime Minister going over going to NATO today to talk about how the UK is going to hit 5% defence spending as proportion of GDP by 2035, 10 years away. The absolute reverse of the peace dividend that we have had since the fall of the Berlin Wall and the end of the Cold War. So that means there's even, unless we are going to raise taxes even higher than they are, bearing in mind they're in a post-Second World War high at the moment, that means something has to give. And with that idea that health spending can just keep on rising, taking more and more of Ardell, which I think it's right, and people will correct me if I've got this wrong, but my interpretation of the recent spending review is that 90% of the increased resource Dell over the spending review period has gone to the NHS. And it feels impossible that that will continue with if you're going to hit 5% of defence spending. So that's the gloomy bit. You may agree or disagree with any of that, but I think we are in an extremely challenging position, which means that the idea that we can have, which lots of people in the life sciences world, and I'd be guilty of this, is like, oh, if only we could spend more money on this brilliant technology, if only we could spend more money on that brilliant technology, wouldn't everything be better? Yes, it would. There's amazing value to be generated, but you can't get the value if you don't have the money. So the critical questions, I think, that we need to answer about how the life sciences can help, to some degree, they start and end with our friends at the Treasury, because, of course, everything starts and ends with the friends at the Treasury. But we've got to apply some stringent conditions to that life science innovation if it is going to help. We cannot just wish that there are billions more pounds to spend on it, whether it's through the voluntary pricing scheme for medicines, whether it's through medtech and digital innovation, whatever. They have to show value to the Treasury, to the taxpayer, if they're going to get anywhere. And so I thought about setting some tests that those innovations might have to meet if they are going to get support from the public purse, in addition to what already exists. So first is obviously efficiency and productivity of the healthcare system. Ideally saving money in a year. That is a really hard bar to get over. But nevertheless, if we're trying to create headroom, then that's something we've got to do. We need to reduce input costs into the NHS, and I'm going to give an example of how that might be done. And of course, we've got to reduce demand for sickness services. And I'm going to go from a sort of vanilla suggestion of how one could do that to perhaps a more provocative one over there. And of course, if we're able to do these things, yes, we will have set stringent tests. We will still be spending £22.6 billion on R&D across the entire economy. The government will be by 2029. But as a result of that, we will increase the amount of FDI, R&D spend, and so on, all those factors which will contribute to growth. So here are a few ideas which we can discuss when we get to the panel. On productivity, the good news is we actually have some fantastic programs already and technologies already in place that have been proven to have clinical impact and also to save time and money. And I've given 3 examples here. The first is, and they've all had backing, it has to be said, from DH government and NHS England. So the first is robotic-assisted surgery. NICE recently did an evaluation of this in soft tissue and in orthopedics, and there is clear value to be had there. And indeed, subsequently, Jim Mackey, the head of the NHS, has announced what he called a robot drive, which I don't know, evokes all sorts of images in one's mind. But the shift towards those kind of surgeries is particularly effective, actually, at reducing hospital days and getting people back into work. The biggest application so far of AI in healthcare is probably in radiology. And actually, again, government has funded a lot of deployments of that, a lot of research, late-stage research into it. But again, you've got the opportunity here to enhance what is actually an understaffed part of the NHS, make more productive the people who are there, and actually be able to serve the requirements with the existing workforce. And then moving into natural language processing, ambient voice technologies, and so on, which, again, have taken off. Indeed, they've been in the news this week because the NHS has said to stop using some of them, but in a good way, because there are a lot out there that have no classification as a medical device. So if we're going to use technology, we obviously want it to know it's safe and effective. So there are a small number of examples that we could use there, all of which are already deeply embedded, but which are not yet scaled. And hopefully some of this increased tech budget will go to that kind of thing. We also need to look at back office efficiency. And of course, this is the boring, less sexy stuff. But it is also where most of the automatable tasks exist that actually wouldn't need human impact. I think it's probably fair to say, and I bow to clinicians in the room, that a lot of the frontline technologies are going to be augmentations to clinical work. They're not going to replace humans. They're going to work with humans and make them more effective. Actually, it's in the back office where a lot of the purely automatable activities can be, and it's the obvious ones like EPRs, but also things like connected medicines management, which is pharmacies, and of course, clinical decision support and workflow. And indeed, we've got good examples of programs which are listed here, which are enabling that today. Again, the challenge is we have never scaled them properly or in a systematic way. And so what would we need to do? Sorry, I don't know why the icons have gone a bit funny there. But what could we do to help that shift? I am going to make the provocative suggestion that we should have as a goal not to increase staffing numbers, but that our primary metric should be the productivity and efficiency of members of staff that already exist. Not my idea, actually, particularly Mark Britnell, who is now chairing Health Innovation Manchester, has suggested that, noting that there is about a 40 million person projected shortfall of healthcare workers globally across the world. So the idea that we are going to be able to pull on those staff is probably fanciful anyway. We need protected multi-year budgets, and Lucy will no doubt correct me if I've got this wrong, but it did seem encouraging in the spending review that that is what is being put in place, 50% uplift in spending and protection for the tech budget, so you don't get money shifted out at year-end to bail out the NHS. Moving funding towards AI-driven productivity and enhancing technologies, and I think the life sciences sector plan might have more to say on that. And, of course, focusing some of that spending where productivity gains have been proven and moving to scaling. And that has always been the challenge in the NHS level. More pilots than BA, all of those kind of jokes. But we have lots of great technologies with small level deployment, but we are not being good at deploying nationally, and that's the step that we need to take. So that's on the productivity side. On input costs, anyone here who knows what I've been up to over the last few years will know I've been involved in clinical trials. I did a review for the government commercial clinical trials, so excuse me while I indulge my hobby. But it is becoming increasingly expensive to bring a drug to market globally. So it actually costs about $2.7 billion to bring a medicine to market. This is so-called E-Rooms law, the doubling the cost over about 8 or 9 years. And the most of that expenditure happens in the clinical trial phase. Right? So we have to address that problem if we are going to reduce the input costs of medicines, because if we've got more and more medicines coming through, which actually the application of AI to things like drug discovery, target discovery, is giving us more shots on goal. But if the cost is ever rising, there will be effective medicines, life-changing, life-saving medicines, that we cannot afford because those are becoming more and more expensive, that are not to do with discovering or even developing a drug, but actually taking it through the clinical trial phase. So this is really mission critical for the future of medicine. And this makes the point here again about where those costs are. I mean, interestingly, it is in the sort of phase 2 and phase 3 trials. So there's late phase trials where the UK has historically been very successful, where we're trying to up our game again. And so there are a number of recommendations which, and Lucy may expound on some of these, including those which have been made recently by government around clinical trials, and expecting a lot more next week. But we have an opportunity here to really globally lead again, in not just in the number of trials that we do, but how we do them and reducing the cost profile. And the UK has amazing experience in doing that, that actually could be brought to bear that would have a material impact on drug pricing globally, despite the fact we're only 3% of the UK market. And I've given some examples here about how we can use R&D tax credits, for example, new regulatory models, and also thinking about non-medicines, because they can often be as impactful, but they don't access statutory funding, and they were often radically cheaper. So we need to think about reimbursement. I think it's fair to say, without giving too much away, a lot of this should feature in the life science sector plan when it comes out. And then finally, just to think about lowering demand. Now, this is the sort of vanilla stuff that I talked about. It is obviously the case that it's sort of obviously the case that early diagnosis will help, so long as you've got therapies that can affect the course of how a disease develops over time. Again, we have tremendous history and I think potential for innovation here. The targeted lung health checks, for those who are familiar with them, is doing a brilliant job in actually shifting earlier stage diagnosis and improving health outcomes already, and we can roll that out. The UK is very good at screening programs, so there are more opportunities to do that in different cancers, particularly blood-based cancers and so on. There's some very exciting work going on in the dementia space, again about blood-based biomarkers, which would make it radically easier and cheaper to diagnose people with early-stage dementias, which actually provides all sorts of opportunities for intervention that don't involve the drugs that are currently not being allowed through by NICE because of their cost profile. And there are also opportunities that we need to go at, which we haven't really cracked, like prostate cancer, where we still need screening technologies. But these will all help, and a lot of these are amenable to behavioural, environmental interventions as well as therapeutic ones. We also have great leadership in the field of personalised medicine. You think of the work that's happened with the cell and gene therapy catapult, Genomics England in rare diseases and oncology, the cancer innovation, the cancer vaccine pathway, vaccine innovation pathway, and so on. And we have an opportunity to take that population-wide, both for rare diseases and for cancers. And I think critically, one of the things that we can do here is to pivot some of this activity away from later stage treatment towards what is called more personalised prevention. Now, some of you will be familiar with the concept of polygenic risk scores, so you take your genetic profile and you look at where your risk factors are. It's in its sort of nascency, but the potential there to understand what an individual risk factors are and to adjust behaviours, diets, even some sort of generic medicines and other things to help them is tremendous. We have small numbers of pockets of examples of it, but we haven't yet scaled it. But the opportunity to put off disease, which will come to almost all of us, but to put it off is where the big economic opportunity lies. And here I've got some examples of absolutely life-changing medicines in spinal muscular atrophy, which are once and treat and totally transform a child's life. So it's not just the prevention, but also treatment at a very early stage. And then the final one, which is the more, sorry, I don't know why the sequencing's gone all funny, but it is more about scaling prevention. So it is fundamentally true that a sickness-based healthcare system will never be able to catch up with that growing demand under the constrained fiscal circumstances. So we need to move into prevention. The question I want to pose is that something the public sector can do alone, or is it something that needs to happen in partnership with private citizens? And let me tell you why I think this, and again, obviously open for discussion, is preventative health is predicated on the idea of an individual having agency. Sickness health is more of a surrendering to expertise. Now, that's crude, obviously, simplification. But it was said in a meeting I was in the other day, someone pulled me up and said, you have to remember the NHS is founded on the idea that patients don't have agency, which is a pretty blunt statement, and I'm not sure it's entirely true, but it's actually quite true. Preventative health is sort of qualitatively different. So we need to find ways to motivate people. Now, we can either leave that to the private sector, 1.5 million scripts for GLP-1s being written privately, Mount Jarrow becoming available yesterday on the NHS for a very small number of people, or we can find a way to combine that. And one of the things I'm potentially most excited about is this being done through the common platform that almost everybody now has on their phones in the NHS app. Not just what the NHS gives, but the opportunity to access, subscribe to other healthcare services, preventive healthcare services that are provided privately and could be co-pay models or indeed subsidised for those who can't afford it, that group who are suffering health inequalities. And I think, given the NHS is founded on the principles this is probably one of the most fundamental questions which we're going to have to grapple with if we're going to get ahead of or back onto that curve of being able to make a sustainable healthcare system that is affordable in the environment that we are living in and which is contributing to economic growth. So I will finish there, and looking forward to hearing Lucy and to hearing your questions when we get to the panel. Thank you.
Great. Thank you. It's now my pleasure to introduce Professor Lucy Chappell, Chief Scientific Advisor at the Department of Health and Social Care. She's responsible for the department's research and development, including the NIHR, the National Institute for Health and Care Research. Lucy is Professor of Obstetrics at King's College London and Honorary Consultant Obstetrician at Guy's and St Thomas, as well as a Policy Leaders Fellow with the Centre for Science and Policy.
Thank you very much, Nikki. James is always a hard act to follow, but I'm struck by many synergistic themes across our talks, and only one shared figure, which is good, so telepathically doing that. I'm also conscious that in the room today, we've got people from a wide spectrum of disciplines. And really, as I was preparing the talk, I wrote it last night, I know, was thinking about how the messages from this sector might well have much wider reach. And so it sort of really got me thinking about how we learn lessons across different areas. So as I was sort of conceiving on what I wanted the messages to be, I often start by visually sort of thinking what am I talking about. Some of you may know that when I did this at the CSaP Annual Lecture, I tried to get a visual image of policy, and that was the most challenging. But actually, what this reminded me is that even visualizing what life sciences is, it isn't straightforward. And to James's point, life sciences now really has got to embrace it's not just big pharma, and if we went down that route, we would be falling into a big bear trap. So it's not surprising that there's a picture of vaccine, but I'm inviting people to think much more broadly about what life sciences means, and to remember that the sector that I represent is universities, trusts, charities, not just industry. And so we've got to make it a very inclusive team sport as life sciences, and not just to do things that will be for one sector or another. I then went looking at resilience. And again, how do you capture resilience? And this is off the UK Resilience Academy, which is a new initiative set up by the government. And again, these sort of threads were things that I really recognised as what we should be talking about today. How do they intersect? Well, I've come from a sort of more conventional clinical academic background into this policy space now 4 years in. And really it reminded me that for many people in my community see me as a research funder as heading up the NIHR. And that's all of these very much more sort of recognisable areas. But actually, we are operating in a health and care system, both when I came in 2021, which has completely changed in terms not just of COVID, but of the wider health and care system challenges that James very neatly outlined in his talk, but also the political context. I sit in a government department, and therefore I am not in a sort of removed from ministers' priorities and changing secretaries of state, of which there might have been one or two. So I've conceived of it as our sort of 1+3 model, which is we should be really clear about our science strengths, and then we should also call out what else we have in an assets approach. Our science is phenomenal, and the latest QS rankings came out. It continues to be phenomenal, and we shouldn't ever sort of lose sight of why that matters as being the crucial underpinning foundation of so much of what we're going to be talking about. But we should also recognise those other three assets, our patients and public. As a practicing obstetrician, I see this every week. And if we forget sort of that's why we're all here in health and care and in health and care research, we'll have missed the point. But actually our workforce, who do get battered and bruised from all sorts of onslaughts. And I think James is right. It's not that we need more of them. We need to think about how to harness and use our workforce more intelligently for their benefit, so that they can deliver the health and care that they strive to do so. And then the system, and where the system, as we all can recognise, acquires barnacles along the way. And undoing the barnacles is challenging. And even though we undid them in COVID, so much of our system slipped back to pre-pandemic times. So understanding the human behavioural science that enabled that, I find extraordinary, because I thought people would have embraced the better ways of working, but for lots of complex reasons, it didn't quite happen like that. So what are the headwinds? Well, I just picked three. James, they complement very neatly with what James has described. There is our shared figure of the baseline projection for public health spending from the OBR, but also on the left-hand side, reflecting where this sits in terms of defence, as you've heard about, other spending, social security, really thinking about what this means and the drive, as people describe it, to bend that curve. Are we really going to march on towards that figure on the right? The second one is demographic trends. I accompanied Chris Wormold last December to Korea, Japan and Singapore to learn what they are doing and how they are taking a completely different approach to an ageing population, which is very much more societal based. It's not seen through the lens of the health and care system. It's seen as how do we do this? How do we all approach this? And the rise of patients with multimorbidity, multiple long-term conditions, is also critical. If you think of how we've largely developed a single disease, single drug model of treatment, when you get into multiple long-term conditions, that model starts to fall over, and we should and could be thinking about it in a much more intelligent way. And the third headwind is the impact of deprivation on healthy life expectancy, as you've heard. And so, for example, 50 years in healthy life against 76 in the most deprived decile, compared to the right-hand end of that, which is so different. And there isn't sort of intrinsic biological reasons for that. That is much wider social determinants of health. So what about if what has been described as either a permacrisis or a polycrisis, what if that became the incentive to change? What if we say, look at those 7 million, that backlog, do we really think that as a clinician I want to carry on doing more of the same to clear that backlog? I don't. I want to say that provides the very incentive for crucial reform and shifting direction. We've got the health mission. We've got 2 weeks ago, spending review. We've got the 10-year plan, which really is intended to integrate with the health mission. And we've got the industrial strategy published yesterday with the life sciences sector plan coming soon. So we've got plenty of strategies. And the question is, well, how do we actually move from strategy to delivery to see what this means? And as I say, I think we should be innovating our way. That's the backlog on the left. And if you look for the plan for change, the milestone that they have picked is this waiting log. And I argue that those 3 bullets of transforming how elective care is delivered, transforming patients' experience, can we do something about the survey, and the model of care, those are all going to require research and innovation, not just doing more of the same. So R&D has never been more important to the very milestone by which the government is going to be judged. So what would imagining the health and care system look like? So for me, at the heart of it, it's embedding R&D across the system, not as a secondary use, but as a primary part of everyone's job, so that you could walk into any health and care setting in the country and meet people who are as excited and embrace R&D and innovation, the pull-through of that research into their practice, because it means something to them. Why? Well, investing in R&D has a return of £13, which is a very nice ROI to send back to the Treasury. It is a really high bang-for-buck investment. And actually, then if I'm going out to say, well, why would you invest in R&D? Better patient outcomes. This is what matters to our patients and workforce. 5% lower mortality odds. What other interventions have a mortality odds like that? How do patients get access? Why do they drive across the country for cutting-edge oncology treatments? It's because they want to be part of that. They want that access. And then just thinking about the 3 million sick days prevented. Why is it better for our workforce? So if you ask our workforce, they want this opportunity to be involved in research. We know that it helps retention, and retention is one of the keys. So rather than just the hemorrhage out, we should really look at how to do that. And it drives satisfaction and reduces burnout. And when I go to work in the NHS, that is what I see as critical. And then finally, it makes for a stronger health and care system. So whether it's the billion of revenue, hoping that the trusts actually invoice for it and recover it, whether it's, when I was talking to a GP audience, they said that CQC rating really would drive them. So it's putting people in their shoes as to what matters in their part of the system. So how might this be achieved? How might this vision be achieved? So my first thing is you invest in the science. Now, I'm a clinical scientist, I would say this. But if you look at the science and technology framework, which was marked against those 8 categories, this was Patrick Vallance in his role as Government Chief Scientific Advisor, reinforced when he came in as Minister in DCIT, really calling out AI, engineering biology, which really drives our innovative medicines to an extent that we are only just comprehending how everything from mRNA vaccines to smarter drug delivery to tech bio. So how do you integrate medicines with tech? connectivity, semiconductors and quantum. Are we in the foothills of how quantum might really change our health and care system? So I think we should continue to be investing in the science, which is the foundational offer to many of our universities, but also in the technologies. The second one I feel very strongly about is empowering the patient voice. As James has outlined, patients are not passive recipients of health and care. They should be empowering it, driving it. We've championed this at the National Institute for Health and Care Research, NIHR, and we've championed it with the 3B part of research, which grew partly out of the vaccine registry. 500,000 people signed up to be part of vaccine research. We should be harnessing that. We should be expecting patients to walk into our surgeries and clinics and saying, what can I take part in? How can I be part of shaping the health and care tomorrow's treatments? And then making the system do that more easily than we do, and really calling out the research of our charities, AMRC, Cancer Research UK, BHF, LifeArc, in how they shape that. And especially on health data. Health data belongs to patients, and the revolution that we hope will come with the announcement of the Health Data Research Service should have patients at its heart. Of course it drives economic growth. Of course we can work with life sciences, but if we forget who is at the centre of the health data revolution, we'll miss all those other opportunities. My third one is to build the right research for research and innovation, the right workforce. So what do I think? You are allowed to be in one of these three states. You are not allowed to block research. Why would you? Why would you want to stop improving our health and care system? So I'm really keen that we invite our workforce and our workforce leads to think differently so that you could enable everyone to be research aware. You could open up all those opportunities for NHS and health and care clinicians to be taking part in research trials. It's really exciting. I know I do this as a clinician. It doesn't double the clinic time. It just makes our treatment offers so much better. And then making sure that we're investing in the research leaders, as we announced with a new joint announcement with MRC and Cancer Research UK about investing in our clinical future leader fellowships. And then finally, fixing the system. Now, I've written incentivising for outcomes rather than activity, because quite often we go chasing the ball on process. And to be fair, the 150-day metric that was announced is a process measure, but it does deliver the outcomes that we want to shift. So sometimes you need a balance of both. But rather than just counting what we do, what if we actually drove incentivising outcomes? And I would put an added bonus for incentivising innovation to drive better outcomes. So they go hand in hand. And through the UK clinical research delivery, which is really built on the recommendations from James's review, is to say we can show where we are delivering, but we actually need to go further. Because what I alluded to earlier about how we've pinged back from the exciting times of COVID, where we changed how we deliver research, and the sky did not fall in. We are seeking to streamline it, to remove the very localised sense of risk and say we hold those assurances centrally and we can help you to become more productive. Because that productivity challenge doesn't just sit in the clinical service, it also sits across our R&D system. If we want to get treatments to patients faster, we need to address this. Is it possible? We did it twice. We did it in COVID, we pivoted our system, and on a slower timeline, we did it in Reset, where we pulled an extraordinary number of levers to say we want a thriving research landscape. So we went from 26% of our studies delivering to time and target to an 80%, and now consistently still over 80%. That is not enough. We now need to really tackle the study setup. How will we know if it's working? Well, thinking about the topic of the conference today, I've chosen to show the National Risk Register. We should be testing this in calms and storms, peacetime and wartime, and say that we should get it working for peacetime. And then when another emerging infectious disease or another challenge comes, our health and care system should be ready for another shock. And that should be our challenge. How sure are we that we could be ready? Because when the pandemic struck, it was the limited resilience of the health and care system, whether it was across cancer services, A&E, mental health, maternity, that really showed up our gaps. So as leader of NIHR, we've sought to really show how we deliver impact, inclusion that speaks to many of these areas about that geographical and demographic reach, how we're going to have to continue to drive innovation, and how we need to see investment, whether it's in the workforce, whether it's inward investment in so many different ways. We can do this, but only if we ask everyone to come together to really address the need. Thank you very much.
Right, well, I'm going to open it out in one moment to you, so do think of your questions. Thank you so much to James and to Lucy. I think you'll appreciate the way they managed to strike some balance between the gloom and the hope. So I have certainly taken that from this morning so far. The first question I was going to ask was about the comment you made changing between the two of you, that life sciences goes beyond big pharma. And when I think of the kind of logos that were in your presentation, James, you've got some very interesting logos appearing there. To what extent are we making the most of the system that generates economic growth for companies that are starting and growing in the UK while recognising they're part of a global system?
Yeah, and actually, in the longer version of my presentation, I have a similar slide to Lucy about the sort of definitional point. And those of you who are also Cambridge affiliated will have noticed some Cambridge smatterings there as well. It's an incredibly important point, and because it comes to Lucy's point, it's the outcome that matters. It's actually not the technology. Understandably, we get excited about technologies, but ultimately it is the outcome that matters. And the UK, like most healthcare systems, has an unbalanced approach to funding medical technologies of any kind. We almost all have statutory reimbursement for medicines of some form, and we don't for medical technologies, whether they're diagnostic, sort of what you might call old-fashioned or physical analog medical technologies or digital health technologies. So even if you have two products that achieve the same end, the same outcome, and one's a medicine and one is not, you'd think that they should be assessed on a similar basis and be funded accordingly. Indeed, that the best value one should be funded over the other. And in fact, that's not how it works. So there are, interestingly, in the field of digital therapeutics, let me just pick that one example, there are interventions that have been proved by NICE that are effective in sort of large population health. So, it tends to be kind of mental health or MSK and things like that, which are approved but not funded. And there are medicines which are approved and funded, some of which have quite significant risk attached to them. And yet they're treated differently. So we've really got to be agnostic about the type of technology and fund what works best. And again, I think we're going to see a little bit of this next week in the Life Sciences Sector Plan, so we can get to a broader view, which isn't so in hoc to medicines. I mean, we all get excited by medicine and medical innovation, but isn't solely focused on it.
Thanks. And to add to James's points, I think we should recognise the huge opportunity, rightly so, of moving from a sort of single modality intervention, which has broadly grown up in the drug or the tech, to the option for combinations, so particularly drug device or drug device digital, or sort of 2 out of 3 of those, and saying that actually the UK could choose to be front of the pack, both for their development and their regulation, but they need a more sort of agile approach on both. But I think that it very much talks to the personalised, to the targeted approach, which is better for patient outcomes. The other aspect of that, which I think, again, the UK should be leaning into, is this concept of research inclusion. So we have the diversity of our population is a very clear opportunity, but only if we work to ensure that our research is accessible and reaches those both most in need from the disease burden, but also from a representative point of view. Because if you think both about drugs, devices, and digital on their own, but also in combination, we need to ask who does it work for, and then be curious about who does it not work for and why. And I think we should think about how the UK positions itself on both of those points.
Thank you very much. I'm going to open it out now and take perhaps 2 questions at a time. So please put your hands up and colleagues will come round. So Sam, there's a question here first of all.
Hi, I had a question around the statistic on 92% of doctors and 68% of nurses would want research in their roles from Lucy's slide. I was curious about the origins for the difference between those two figures and what might be putting nurses off engaging in the research. I know that for doctors, being on research projects and research papers can improve your career prospects, so I can see why that number might be more inflated, but for the nurses, maybe not so much.
That's a good one. Hold that one. And do we have another question? So also, Sam, could you go around to the lady in the striped shirt at the back, on the third row from the back, or one of you will reach her first.
Thank you. So my question really is, it touches a bit on what both speakers have said. So in terms of, I'm sure generally we want initiatives that are cost-effective for the government or for NHS, but when it comes to the reality of, if we're on the ground, for example, we can't ignore subpopulations. So when you talk about the role of the life sciences innovation, are we at this stage also considering the different populations that we have? For example, you talked about cancer and how our outcomes are currently poorer than other countries because there isn't one cancer. You've got many different types. So again, like you're saying with personalized medicine, it puts a financial strain on the system. So I'm just thinking of cancer as an example, even children. If we talk about pediatrics, we've got so many different subpopulations within that. And that's not always a cost-effective way. So how are we navigating that?
Great. So question about nurses and research and then about subpopulations. Yeah.
So really interesting. I was thinking my job is done when that survey shows that 100% of every health and care professional would like research. And actually, I would use it more broadly. I talk about research, innovation, training and education because I think they are all parts of the same concept that people would like to improve from where they are now to a vision for the future. And that's not a 5 to 10 year vision. That's a vision for 1 year, 3 years, 5 years. We have some, I've got another slide with unpublished but shortly to come out data we did a report from OSCA, the Office for Strategic Coordination for Health Research, which looked at the decline of clinical academics, and we've done a similar report for nurses, midwives and allied health professionals, looking at the number per 100 full-time equivalents. We have a huge nursing workforce in the NHS, and they are underrepresented in research. And that's because quite often, even going back to their undergraduate curriculum, they've never been sort of introduced to the idea. So the NHR has launched a couple of campaigns. One is called Your Path in Research, and the other is called Shaping the Future, which really invite people to take that first step. Because the answer to why is it only 67% is because sometimes either the system makes that first step look like too big a jump, or sometimes we invent bureaucracy to try and make it too complicated. So we should look at ourselves first and say, how do we make it accessible? And we've done that through a whole range of things. So the NHR has a studies portfolio, which has around 6,000 studies. And the invitation is, how can you be part of that? So as an example is our associate PI, Principal Investigator Scheme, whereby resident doctors or nurses, midwives, or anyone can take their first step to being involved in a study. And it doesn't seem remote. It seems like something I could do. If you can see it, you can be it. So somebody like me, I don't mean me literally, I mean that anybody who is part of the health and care system can see themselves in those roles, work to do, and we acknowledge the challenge, particularly because the way that nurses and midwives, allied health professionals, are looked after by their employers when they want to step into research roles is not really equitable. So we've been doing some other work on that. But thanks for the provocation, because it's absolutely spot on.
Yeah, I mean, just on Lucy's point, I mean, there's obviously some cultural baggage, historic baggage, which is probably behind those figures as well. But of course, nurses are just as important in delivering research as doctors are. And actually, if we take the sort of view, which I think we share and lots of people have, but maybe we don't enunciate clearly enough, which is that research is fundamental to good care. It's not just research that active people deliver better care. We don't get better care without research, and maybe we need to be clearer about that. That actually Lucy's quite right, everybody should want to have research in their role because it's important to understanding how to improve care over time. On the subpopulation, I think it's a brilliant question, and Lucy and I were sort of talking about this actually before the panel. You know, a lot of it comes around to data. So we have good characterization about some populations, deep characterization of some populations. We have good but shallow characterisation across most of the UK healthcare population, but we have some very significant gaps with certain communities and in certain disease areas, which must inevitably mean that the care opportunities, research opportunities are not evenly distributed. And I think that comes through in the research activities and the healthcare outcomes that Lucy and I were both talking about. So I think, I don't know, there's a lot to unpack in your question. It's a great question. One thing I would say is we need to be in a position where every single patient who is treated by the NHS in 4 countries of the United Kingdom is equally well characterised over time. And I think some of the pledges that we've had on this single patient record, the promise to do genomic screening for all newborns going forward and so on, mean we should be in a position over time where we'll have multimodal data about everybody in the population, and of course that has got to be presented as something which is good rather than something which is in some way sinister. Which, you know, this trust level, we can't underestimate it. You've got to keep hammering away all the time about data is necessary for healthcare delivery, for improved health outcomes, and that the way we deal with data is done in a way that's safe and legal and ethical.
Absolutely. Thank you. I'll take a couple more questions, please. So Sam, could you come down with the chap here in the blue shirt?
Thanks. So I'm interested in the curative to preventative shift you've talked about, and the NHS is a behemoth and it's hard to transition. I wondered if you could comment on some of the structural financial mechanisms to drive that change. For example, bringing health-related welfare payments into the NHS budget, or payment for disease prevention rather than procedures completed, that type of thing. Thank you.
Very interesting. And one more at this moment. So just across the aisle there, Sam.
Hi, mine's also on prevention, incidentally, and that's how can we facilitate people engaging with preventative medicine, and especially in more deprived areas where people have a lot of other pressures on their lives, and they have not just financial pressures but also time pressures. How are they going to engage with the healthcare system in a preventative way when there's not something obviously wrong? And I know there's data to show that cancer diagnoses in more deprived areas are often through emergency settings, not through other diagnoses.
Great. So structural and then a kind of incentives question for engaging with prevention. Who would like to go first? James, do you want to?
Gosh, yeah. I mean, these are massive questions, aren't they? In terms of the financial models, I mean, So I think there is a fundamental challenge, if we're being honest, and I can say this because I'm not in government, about this shift from curative to preventive, which is not really curative, right? Let's just call it treatment to preventative. Because, of course, we all still want treatment. We need treatment. So the language has shifted from sickness to prevention, which is, of course, the right way of thinking about it. I think, as I was trying to get to in my kind of last slide, there's a really fundamental question here about whether a service that was set up to treat, and indeed in some cases cure people with largely with infectious diseases when it was set up in the 1940s, is capable of making that shift to delivering preventative care at all. Now, it clearly is the case that the healthcare system, often not the NHS, does deliver preventative healthcare. We do it through public health, we do it through our screening programs, we do it through vaccination programs and so on. But if you think about the sort of tech-enabled behavioural requirement to move to preventative care, is that something which the NHS, which, let's, you know, as I said, is struggling to do its main job at the moment, can actually shift to? And I have some fundamental questions about that. So that is why I'm interested in this idea of individual agency, because I do think there is a moral hazard problem here, which is with the NHS, you know, if you get ill, there is something that will pick up the pieces, and that's a wonderful thing. But it also does somewhat reduce your incentives to stay well. And how do we introduce those incentives that gives people agency, but actually, to the second point, make sure that it is evenly distributed, is, I think, the fundamental healthcare delivery question that we have in front of us. So all I've done is restate your two questions. And I do not have the answer to it. But what I do see is that people are already behaving with their wallets. So I mentioned the GLP-1s. If you look at instances of accessing primary care, for 19 to 24-year-olds, more than 50% of them. Their use of primary care is delivered through self-pay in the private sector. So there is a generational shift going on in people's willingness to pay for healthcare. And I wouldn't discourage that. I think it's a good thing, but it could be a bad thing if it creates more of those health inequalities. So how the health system responds to that, as I say, is I think arguably the biggest policy question in healthcare at this time.
Thank you. Agree on sort of how these questions are really getting to the nub of our challenge. If we were in a rising budget, we could probably have a go at both. Yeah. We could continue to fund the treatment that we are, and we could increase our spend into prevention. It is not like that at the moment. And I think one of the challenges that we should be thinking about as a government, and arguably they're aiming to do that with a mission-led approach, but also with society, is how the wider determinants of health do not sit within DHSC. And you can all think of examples across transport, housing, alcohol policies. There are better examples of, for example, smoking and the tobacco and vapes bill, where we've got that political will to deliver on something that often needs that real cross-government buy-in. One of the areas that we funded at NHR is something called the Health Determinants Research Collaborations, and we said that they had to be held by a local authority, because our local authorities are responsible for a reasonable amount of our prevention services. And we watched as a little bit like the earlier question about getting nurses involved, we watched how keen the local authorities were to engage with this, so to find out and to go for an evidence base, what works, so that they could enact that in their local areas. And then they needed to partner with lots of people locally, whether it's the universities, the trusts, the third sector. So they were driving that approach. A conventional way of looking at it is primary prevention, which is often done at a population level in the sort of pre-symptomatic space, and the secondary prevention, and we should think about attention to both. So the secondary prevention should be done by broadly everyone across health and care, so that you might pop into your GP for a skin problem and they opportunistically ask to measure your blood pressure. So rather than taking a very sort of reactive wait for the disease to appear, there are many ways in which we can both, we have to think about that sort of population-based model, but using far more sectors, the supermarket sector, for example, and then also think about the secondary prevention. In the 10-year plan engagement, there was the tension that James has absolutely named, which is how do we give individuals agency and that sense of responsibility for their health that is not widened by deprivation. So not in a blaming way, but in an empowering way. And that is something that I think we've still got a long way to go on. So slightly restating the problem, but asking everyone to be involved, because it won't just be people on the panel who hold the answers. It is going to be people in the room who have got their piece of the jigsaw.
Can I just quickly follow up one point, because Lucy's quite right to say about, restate this fiscal problem. There effectively strikes me there are two places that everyone would agree that we don't want to spend money at the moment. One is on servicing our debt. We don't have a lot of choice about that. And the other is actually on a large portion of the DWP budget, right? There are lots of people who would like to be back in work, who are not in work for reasons of ill health. I talked about some of those numbers earlier. Now, what's interesting is those factors, getting somebody back to work, is not included in the evaluation methodology that NICE uses when it's looking at the value of medicines. And there's a very interesting study done by NHS England which looked at the impact of bariatric surgery, which of course itself I assume will be a thing of the past quite soon. In terms of, so they managed to bring together health data, HMRC data and DWP data, and look at the total ROI from a fiscal point of view, which is a unique study to my knowledge, that showed that there was a ROI within 2 years on that and continued for many years to come. So a really, really good value for money proposition that would have made, if you applied that methodology today to medicines, population health, preventative type medicines and respiratory and diabetes and other things, would probably mean that we had more and a much faster ramp up and access to those medicines than we do today, and that they would simultaneously save money and get people back to save the fiscal treasury money and get people back to work and therefore contribute to growth. And so I think there is a really interesting opportunity which has been hitherto just not explored, about how we can cross departments, cross silos, bring data together to take some of the people who, because they're out of work, they will be among those poorest people. They will have the poorest access to healthcare generally, and give them enhanced access, rapid access, priority access to some of these medicines as a way of getting them back into work, and with all the benefits that we know come from employment.
Fascinating, thank you. I'm going to take two last questions. So, Sam, if you could come down here, I've got two conveniently sitting next to each other, which makes it easy to see. So on the second row.
Hi. We're talking about integrating new tech into the NHS, but the NHS already has a lot of tech in there. I was wondering if there's any push towards integrating the healthcare worker-facing tech together. Speaking from experience, I worked in 3 different NHS trusts, and each one had completely different systems. None of them talked to each other, and it was a large bulk of my work involved being on the phone, trying to contact people from the other trusts, trying to find patient information. We spent a lot of time on that. On top of that, one NHS trust, I had 2 logins. The other NHS trust, I had 7 to do the same things. It just feels like a lot of it's a big mishmash of systems that we've tried to integrate, but it's trust by trust. So I was just wondering if there's a push to put them together, integrate them together.
That's a great question. And then your neighbour.
I just wanted to ask a question about that tech adoption policy and making sure that it's offering the maximised UK economic growth. So, for instance, on your slide with surgical robots, there was obviously CMR Surgical, company based in Cambridge, manufacturing in Cambridge, versus Intuitive Surgery, who I think are headquartered in the US and manufacture in the US. Obviously, the economic benefits of the procurement of CMR Surgical is much better from a UK perspective. And so how do we make sure that, again, very welcome news in the spending review about strategic partnerships, how do we make sure that those strategic partnerships are sort of catered towards UK companies and make sure that they are given the opportunity to scale, which has a knock-on impact in terms of sort of exports, etc.
So shall I pick up the first and then I get to give the second one to Jake? So as a clinician, I completely recognise. I think we've got to see it from two ways. One is just improving the interoperability of our technology. But we can both drive that through a push and a pull. I think it is happening, and for example, on the Health Data Research Service, where we know that we've got data sets sitting in many different places, so the technology integration engine will be a key part of getting the data to talk to each other. But I completely share your frustration of multiple logins, and asking, or we are seeing, so in London, the London Care Record has made a big difference. On the screen in front of me, I can click and I can see on my computer, I can see can get access. So it will come, but we should drive it with that pull. The other bit of it that we have not really touched on is this difference between where I think quite a lot of medicines adoption has been additive healthcare, so you can go to your GP and you can get another pill prescribed. Technology often needs a replacement care pathway, but that has got quite a lot more inherent inertia in the system, which sort of leads to these sort of patches, a bolt-on technology, which doesn't actually adequately look at the replacement pathway that would be preferable. So it works in two ways, replacing a whole care pathway. So, for example, if you're looking at screening, you have to switch from one to the other, and that's why it often takes quite a long time. One of the investments we've made recently is the digital infrastructure for AI screening, so that rather than each research use coming along and using a different AI platform, we're investing with the NHS in a sort of a single platform, so that we can push through our AI screening trials rapidly rather than doing it in a very sort of linear, sequential, inefficient way. So I think we need to better consider how we do switch in new technology that doesn't just put a sticking plaster or a sort of a temporary fix on all of those problems. And again, that comes back to sort of system change and that system vision. And then James gets the second one.
Yeah, well, just on that point, when I was a minister, I was charged with implementing the recommendations of the Accelerated Access Review, for those who remember that far back. And one of those was a pathway re-engineering fund to exactly address what Lucy's describing. And I was subsequently told by private office it had gained infamy as the only fund which the department had ever launched which didn't go fully spent. Which is fascinating, isn't it? That tells you something not just about the demand for it, but actually even the engineering capability within the system to do pathway engineering. So Lucy's quite right. I think it's implementation science, and actually that isn't or hasn't always been a strength of ours. So on the sort of tech adoption, first of all, I declare a couple of interests. New Market Strategy, Intuitive Surgical is a client of New Market Strategy, and obviously CMR are in Cambridge, and I've got my CUHP hat on. So, you know, just putting those out there. I think you're quite right. I mean, this is the balance between clinical impact and economic growth, right? And I think it's the case that all of us would prioritise the former over the latter, individually. But of course, the question is about collectively. And I think this gets to a really important nuance that I would want to describe in the industrial, or what a good industrial strategy should be. We're all familiar with the sort of phrase picking winners. And indeed, the industrial strategy just published, I think, uses the phrase taking punts. Which is a slightly looser, more cavalier approach that was in the ministerial forward. That is the wrong approach. The right approach is to pick competitions, not winners. And we know that quantum robotic-assisted surgery, voice recognition technology, AI, those are competitions of which one or more company will be the winners because they are the best. And indeed, who wins will change over time. What we cannot do is say, right, we're definitely going behind that one or that one, and putting all our hopes behind them, because, of course, we know from history and indeed economic literature that doesn't work. So it's about picking those areas that we know are going to be fundamental and supporting them in a variety of ways without jumping on one horse or another.
Thank you very much. Well, that was absolutely fantastic from both James and Lucy, and absolutely eye-opening, I think, for the challenges ahead and the opportunities too. So I'd invite you all to show your appreciation.